Welcome to today's episode, brought to you by the Women in Medicine Summit, a transformational CME conference happening September 13th to 14th at the Drake Hotel in Chicago. Engage in leadership programming, learn negotiation skills, receive on-site coaching and mentoring, and see who will win this year's I Stand With Her awards. This year, we're excited to offer unique programming that includes a special session on how using improv comedy can bring fun back into medicine. We also have financial sessions tailored to help you navigate the complexities of personal and professional finances. Discover ways to advance into leadership roles, combat burnout, and either reignite your love for your current role or find joy in a new career path. Don't forget our Friday evening gala, a highlight this year you definitely won't want to miss. Register now at womeninmedicinesummit.org and be part of the movement that is shaping the future of healthcare. Join us to network, learn, and celebrate the power of women in medicine.
Welcome to the Revitalizing Doctor podcast. We interview trailblazers in medicine that embody the Revitalize Women vision to empower women to innovate and influence medicine, to value authenticity, respect, and work-life harmony. We recognize the challenges in medicine, and we're committed to providing coaching-informed strategies to help you go from surviving to thriving. I'm thrilled to have Dr. Raquel Harrison back on the podcast. She has been a guest before, and today we are going to be talking to her about some updates in her work as both an emergency physician and a lifestyle medicine physician. And this is going to be a great episode if maybe you're thinking about, do I still want to practice clinical medicine? And I think where our stories converge a little bit is we both came pretty close to maybe not doing any clinical medicine.
Right.
So in this first part, let's focus on this tension between practicing clinical medicine and not practicing clinical medicine. So what are your reflections on that?
Andrea, thanks for having me. It's so great to be back with Revitalize. I love what you guys are doing, and there's so much power in it that just creating a space and a conversation about some of these issues that a lot of us struggle with, and we never have a chance to kind of hear what other people are doing. And so I love what you guys are about. You know, it's interesting. I went part-time, and I think I talked about this in the podcast a bit, but I went part-time probably about 5 years ago, really trying to understand what my life clinically was going to look like. And, you know, as emergency physician, big, large academic urban centers, that's what I've always known. And in that kind of part-time journey, I found lifestyle medicine, which is almost in some ways like the flip side of what we do. But as I've kind of gone through that journey and started to do more with lifestyle medicine, and even, you know, in some ways reduce my time in the emergency department more and more, I haven't wanted to let it go. And part of it's because, you know, there's always kind of that nagging of I've worked so hard to get there. But also it's grounding, right? It's that ability to remember why I'm even having some of these lifestyle conversations in the first place. And a lot of it is, you know, if we really kind of peel it back, those patients that we're seeing in the emergency department are often the culmination of a lot of bad lifestyle decisions. And sometimes it's actually just one lifestyle decision, depending on the patient, but it's that culmination. And so it's a little bit of that reminder for me why I even, you know, opted to take the other approach for a little bit. And so I still practice a few times a month. I'm blessed to be in a position where I can do that with my boss and with my family as well. But it's definitely giving me a bit of a different perspective on my clinical work in the emergency department.
That's so interesting. I just had another call with a senior emergency medicine leader that shared a very deliberate decision to keep doing one shift a week. And we explored that because she was in a position where she could have said, I'm not doing any clinical. And the thing I keep coming back to is the thing that got you into clinical medicine may not be the thing that keeps you in clinical medicine. How does that land with you?
That's an interesting way to phrase it. So that idea of the clinical not actually being what keeps you clinical, it's interesting. I think that does resonate for me, because in some ways I have an opportunity to go in, not be overly frustrated, not feel burned out. I'm going in because I enjoy it. I enjoy the opportunity to kind of interact with different kinds of people that I don't otherwise interact with on my day-to-day when I'm not working clinically. But also, and I think I used this word earlier, but that idea of staying grounded, not only to kind of the realities of medicine, the realities of health and staying healthy and what that looks like, but also grounded to like my own journey within medicine. And so it's a good reminder on a fairly regular basis of my own motivations and my, pathway through all of this to try to really hone in on who I want to be in the future as well.
Now, one of the other things I've noticed about my clinical time is, of course, it's about the patients, and you want the patients to have a great experience and be safe. And that's kind of almost a given for me. Like, I'm saying it so it's very clear to anyone listening that the patients are always the top priority. But at a certain point, when you've had this much training and this much experience, it is a given that that's what you're going to do on a given shift. And so your bandwidth and capacity to be accessible in different ways. And, I had a shift recently where it was a newer attending that I actually knew from when he was a resident. And we were sitting side by side. And I love that in this particular emergency department that you sit next to another emergency physician and you help kind of field calls. So the calls aren't always going to one person. And there were all these different things that kind of popped up during the day. And I was able to, just kind of say, when I had something similar, I found this was helpful. And I did it in a way that, I've had people insert themselves into my cases very rudely and very condescendingly. So I, asked permission. Could I, share something with you, or could I tell you like how this happened? The similar situation went down with that consultant, in a previous situation. And it ended up being a really fun shift because I could see him about to step in some big piles of poo. And I just helped him step around it. And I think that was more rewarding to me. Like, honestly, the patients I saw that day, there was really nothing that exciting or interesting. I had some nice conversations with them, but it was the interaction of being there for my peer that provided a lot of meaning to that day.
I would absolutely echo that. I mean, even just the opportunity to, when people ask you how you are when you walk in and you've got a smile on your face because you're there for different reasons, or you're able to be there in a different capacity because you're doing other things when you're not there, that also offer that fulfillment that you for years anchored on your clinical work providing, right? You're not looking for that anymore. And so you can offer yourself in different ways.
Yeah. And the other thing that I've been on the verge of, do I go, full time into whether it's coaching or simulation work and leave clinical behind? And the interesting thing that has got me really taking pause is, like you said, we've accumulated a huge amount of wisdom and experience. And honestly, if this podcast gets forwarded to a administrator, what should keep you up at night is losing your mid-career docs. Because let's be honest, some of your really at the very edge of their careers do a great job, but a lot of them, the data actually shows that after the 10-year mark, people, if they don't do very deliberate things, will lose expertise. Your new docs, they're great. You want to keep them happy too. But your mid-career people that are exiting, to me, should really be concerning to folks.
I agree. You're talking numbers, repetitions, all the things that we highlight as really important, particularly in emergency medicine, right? That ability to understand the algorithms and deviate when needed. All of that comes with good training, but also an accumulation of just cases, right? When you start talking about like kind of try to extrapolate the numbers of patients you've seen over time, an emergency physician in a big urban emergency department working full time, you'll cover 3,000 to 5,000 patients potentially in a year, right? Like, I mean, that's a lot of repetitions. That's a lot of accumulation of cases over time. And it's an important piece, you know, medicine doesn't change with that much frequency. That 10-year mark, I think, is pretty critical. It's also probably why I would say I feel comfortable doing a reduced shift load, right? And still being okay being in the emergency department when I am, because I do feel like I've accumulated that experience and can draw on that. I do get that question a lot. Do you feel comfortable even though you're working so much less? And it's to that point of after accumulating a certain number of cases, you really do have an expertise that's important. And it's not a matter of like inflating myself. It's really just that mid-career physician that I think you highlighted.
I also want to explore this idea of, I think both of us went through periods of burnout to some degree. And I think a lot of the burnout, self-help books, resources, coaching programs, whatever, you put in burnout and physician into Google, what pops out is this is really bad. And here's something you can do to make it better. And it's almost like, if you had an infection, like, okay, we got to pop this abscess and get you on some antibiotics. And one of the most powerful things that came to me in the last 6 months, and one of them is a past episode with Michelle Woolhouse that really introduced me to this concept, is what happens if you took away the idea that the burnout was bad and that it's something that has to be reversed. And instead, you followed it down. Like you didn't repress it. You didn't try to figure out a way to fix it. And I don't feel burned out now, but it was almost like if I could have befriended that time, if I could have said, this is actually trying to teach me something. And what it was trying to teach me was how to reshape my career to move in line with my values, boundaries, and priorities. So all the quick fixes like, okay, well, I'll switch to this job or I'll reduce shifts here. It's almost like a tummy tuck. You're trying to do the tummy tuck instead of the lifestyle medicine approach. And it wasn't working. And it was really going through the soul pain of what is this trying to teach me? And I think, looking back, I had burned out a few different times. And it was only the last time that I just really leaned into, no, it's something's happening. There is no quick fix. It's going to take a retooling, revitalization of my career in order for me to keep doing this work. So I wonder what your reactions are to that, or if you had a similar experience in any way. Stay tuned. We'll be right back. Are you a physician mom with school-aged children feeling utterly exhausted? My friend Dr. Sheeta Shaffi invites you to take a little time this summer to join her in a small, intimate group for meaningful conversations. Dr. Shaffi is an emergency physician, coach, and mom to 8-year-old twins. She understands firsthand what you're going through. This isn't a pizza party or a yoga class. You'll meet for 2 one-hour sessions twice a month starting in July to help you move out of exhaustion, let go of mom guilt, and live a life you're not only proud of, but can truly enjoy. Connect with her on LinkedIn or Instagram at Sheeta Shafie to learn more. Sheeta is spelled Shideh, and Shafie is spelled Shafie. You can also check the show notes for a link so you can connect with her there as well.
Yeah, I think it's an interesting concept, an interesting idea of like, how do you just keep kind of peeling back the layers in a sense, right? To try to really uncover the why behind the burnout, right? And in some ways, I feel like I probably came right up to it, and maybe I was burned out like fully. But I think kind of coming up against it, being forced to, because of, some personal health things I was going through. And maybe it's my optimistic perspective that's like, I wasn't quite at burnout, right? Or maybe I just butted next to it. But it's really the why that sticks out, and kind of embracing that in some ways and allowing myself to be frustrated with what I was doing every day. We get really stuck on this idea of like, man, I chose this path and it was a really long, hard path. And so you almost feel like you were supposed to be victorious at the end and you're not, right? And you're just like, I'm frustrated. It's not what I thought it was going to be. And there's no like reverse, or at least it feels like there's no reverse. What I love about what you said is it's a little bit of, okay, how do you harness it and then take it potentially just in a little bit of a different direction? It's not a full reverse, but a pivot per se. That's lifestyle medicine's really offered that, because I'm able to leverage my perspective in emergency medicine. And actually, when you start talking to people about their habits, their lifestyle choices, their day-to-day, that ability to read people quickly, translate really complex medical concept into lay terms very quickly and have things resonate, really like tools I use regularly with when I'm doing more of the lifestyle medicine work. And so ultimately it's the frustration with kind of that day-to-day feeling like I was only putting band-aids on people, like just really fancy band-aids, and then not feeling like I had much to show for it, and not really getting at the heart of what actually prompted me to go into medicine in the first place.
Yeah. As we close out like this first part about how your clinical time evolves over your career, I'd like to give some people some practical tips or like things to noodle on. I think one thing is you should recognize that the amount of investment that went into your clinical expertise is huge. Financial, time, all of that. And, given the moral injury and things that happen to people throughout their career, it can be very tempting to just let it go and do something else. Every physician's incredibly smart. They can definitely succeed in real estate or whatever thing you want to do. And there's nothing wrong if that's ultimately what you choose to do. But make choices from a place of strength and not from a place of fear or desperation. And the other thing too is like, if you're going to go completely non-clinical, make sure you understand what that means and what doors you will close. It was interesting when I talked to a locums company, they look at your cases from the last 2 years. You actually can't get malpractice insurance if you haven't had a certain amount of caseload in the last 2 years, at least for a lot of the locums companies. They look at volumes of the places you work and the breakdown of patients, peds versus adult. And when I did the calculation that they were giving for EM, it came out to roughly about 8 shifts a month over a 2-year period. We can argue whether that's right or wrong or whatever, but it does, I think, behoove you to find out and do some research about if you ratchet down your time or you walk away, what would it take to walk back through the door? So you know, because the other thing I'm starting to learn with some of the non-clinical work is we saw kind of the EM workforce be stretched and stressed during COVID. If you go into a non-clinical role and your hospital decides to cut back on admin, you could be on the chopping block. And then what does that mean? You know, if you're very tied to a geographic area and you can no longer go back into a clinical role and you need to stay at a certain level in a non-clinical space, then you're looking at moving. So those have been some of the things I've been thinking about as I ratchet down my clinical time. And I think these are really complex things, and it helps to keep notes and it helps to talk to other people. What are some practical tips you have, or things that I've said that, you know, you want to kind of double down on, or like that are relevant for you?
Probably the thing that stands out the most to me is like maintaining relationships, right? That idea of understanding. And it's part of that keeping the doors as open as possible, because all those things you just kind of highlighted is how do you keep your doors open that gives you the most, or the ability to pursue what you want to pursue and have options later. And so I think, you know, as life changes, as your priorities change, or your current season of life changes, a little bit as an aside to highlight, one of the things that Revitalize does so well is like helping you really think through and highlight those priorities, creating boundaries around them, putting those in the forefront. And then as you kind of look at like, okay, what's doable, what's practical within the constraints of things that are important to me, whether it's geographic reason or time with family or kids or raising kids. What I think's been key for me is making sure I maintain good relationships within that clinical space. One, so that I could have good conversations with the people I work with, my boss, around these concepts, right? Like, what do I need to do to make sure that I'm staying up to date clinically, but also able to kind of continue to be a contributing member of the team, even though my hours are reduced. But then also, it's funny because in medicine, we don't typically network, but it really is important. And it's a really big piece of like that diversification. People in business are phenomenal at this, but just that checking in every now and then with somebody you used to work with, or because, you know, depending on the circumstances, if you are in a situation where, you know, you're an administrator and the position gets cut and it's not about you personally, if you've maintained a network, you can make several phone calls to just start conversations. That's a really big piece of this. And I think actually a really big piece that I've just increasingly moved more towards is the idea of just relationship in general, and trying to rethink the way I look at medicine as a relationship, whether it's with colleagues, with my patients, rather than a transaction, which is fortunately where I think so much of it has gone. And so to switch into that framework of what's the underlying relationship here has been really powerful for me too.
Yeah. Any other closing thoughts before we move into part 2, which will be more focused on lifestyle medicine, about how clinical time has evolved for you?
We touched on it a little bit, but it's really that idea of kind of finding the joy again, and just that opportunity to take a step back and look at it more objectively and more relationally. You know, that ability to kind of have a new lens towards your clinical practice really helps.
Well, thank you. This has been such a joy to have you back on the podcast and rethinking how our clinical time evolves and how there might be new opportunities to rekindle joy, even in the midst of some challenging circumstances in healthcare right now. Thanks for listening to The Revitalizing Doctor, a project of Revitalize Women Physician Circle. Our mission is to connect women physicians and allies through innovative, value-based coaching methods to ignite the courage and clarity necessary to create change and thrive. If you are interested in working with us, check out our website, peoplealwayshcc.com/revitalize. This podcast represents the views of our hosts and guests. It does not reflect the views of any institution we work for or with. Podcast production assistance is provided by Caitlin Din and Ali Dingus. Sound editing for this podcast is brought to you by Better Podcasting Services. You can find them at betterpodcastingservices.com.
Hi, it's Dr. Risa E. Lewis, dropping in to tell you about a book that Dr. Adara Landry and I wrote. It's called Microskills, Small Actions, Big Impact. It's a business self-help book coming in 2024 by HarperCollins. Pre-order now, Microskills, Small Actions, Big Impact, wherever you buy your books.